There are different types of sealants that are available on the market, ladies and gentlemen. The most commonly used are dental composite resins known as BIS GMS, or resin-based fissure sealants that are used basically to enhance the flow that is typically required for sealants, and these composites have been diluted and are thus less viscous. Ne? So composites that are basically used for sealants are either unfilled or filled. Ne? The filled composite sealants contain a small amount of quartz as well as silica particles. Ne? However, the unfilled sealant materials do not usually require an occlusal adjustment after the sealant is placed and basically completed and polymerized. Ne? So I'm just giving you guys just a general background onto that. But for occlusal adjustments, we basically make use of a disc, a stone, or a burr to just reduce that occlusion and make it more comfortable for the patient. Ne? So with these sealants as well, they require no mixing because they usually come in syringes with disposable applicator tips, cartridges with cannulas, so those are our small hollow tubes for application, or single-use dispensing tips. So I'm just trying to just familiarize with you guys with the types of materials as well as disposing instruments that are available on the market. So, ladies and gentlemen, please also be aware that there are two different types of polymerization methods associated with fissure sealants. Ne? So, the major difference between the two types is that one actually self cures and is part of a two-part system that has a base and a catalyst, or else the other one, most commonly used one, is the light cured system that does not require mixing, but it actually hardens during exposure to light. So the chemically cured one, so the one that has a two-part system being a base and a catalyst, it is also known as self-curing or autopolymerization. Eh? It consists of a base and a catalyst, as I had mentioned before, and then when the two are mixed together, they chemically react and polymerize within about a minute's time. Then the second type, which is the light cured one, the commonly used one, as I'd mentioned before, makes use of a curing light that is used to harden the material. Ne? So they are then packaged as single component systems that are activated by a curing light. The advantage of this one is that there's increased working time, and the operator, being the dentist, has control of the setting time, and there is no mixing required in the process. Earlier on, ladies and gentlemen, I did mention that you must be aware that dental sealants are not always opaque or tooth colored. So like I said, most of the time they can be clear tinted or opaque, but as time is going on and there's greater development of material, we're basically starting to see color changing sealants, which are a very new, more expensive, but increasingly popular option. Ne? So these sealants basically contain a photoactive color additive, ne? And they are usually tinted, usually pink or green in color, and with the initial application. Ne? So basically, as you cure it, they change to an opaque white after being cured. Ne? So this improvement in sealant design allows for a better visibility during the sealant placement. Ne? So that's basically why it is being used, and actually makes the patient more excited because obviously everything is in color. So they're just like, ooh, this colorful sticker, or I have a colorful sticker in my mouth. Ne? I won't go into much detail with fillers, ladies and gentlemen. I've touched on that earlier on when I was discussing with you guys that the most commonly used material for dental sealants are your dental composite resins. Né? So they're just touching on that again, that these composite resins can either include fillers or not. And like I'd mentioned before, the fillers basically contain, the ones with fillers inside contain a small amount of quartz as well as silica particles. Ne? But the ones that are unfilled do not usually require an occlusal adjustment after you've actually cured them. So that's basically what this slide is talking about. Ne? So from there, ladies and gentlemen, your slides then continue to talk about the placement technique that we use to place dental sealants. So basically, you're going to now identify the tooth, clean it, either with rubber cup and pumice most popularly, but others also just take shortcuts and actually just clean with a 3-in-1 syringe, and then they follow it up by just drying it with air that comes from said syringe that you guys find on our dental chairs. Thereafter, we try to get a mechanical bond. So retention of the sealant, ladies and gentlemen, is attained by etching the enamel. You must remember I said there are no cavity preparations associated with dental sealants. So we etch the enamel with 37% phosphoric acid, and then after etching, we're going to rinse and dry the enamel and then isolate the field before we actually place the fissure sealant and cure it. So isolation can be done via rubber dam, which is a very popular option, but sometimes if a child is not cooperating, we end up just making use of saliva ejector as well as cotton rolls just to try and isolate the tooth that we intend on working on. Then from there, our sealant, depending if it's filled or unfilled, tooth colored or photo additive, we basically apply it to the pits and the fissures and the surrounding enamel, and then it is then cured. Curing usually takes about 40 seconds to be successful and adequate. So any moisture on the tooth could result in failure of the sealant to adhere. Ladies and gentlemen, this is not a joke. It's actually like fissure sealants want the field of work to be as dry as humanly possible. So any moisture bring it from saliva or blood for whatever reason could literally result in a failure of a sealant to occur. Okay, so moisture also that leaks water into the air or even from the patient's breath can actually even have an effect. Okay, so the sealant could be immediately lost literally after curing. The moment you start doing your occlusal reductions, you'll find that the sealant pops out, or it can actually be lost at a later date, but basically it will get removed if moisture or the dryness is compromised. So as well, that being said, leakage can also occur during the or around the partially retained sealant, resulting in decay beneath the sealant. So we do sometimes experience quite a bit of problems associated with sealants, but there are ways in which we can try and prevent these problems, such as in the etching phase. You may encounter that the tooth may not be etched completely, leaving voids on the surface. After the tooth is etched, we must carefully examine it and make sure that there are no voids or air bubbles, as the tooth will then need to be re-etched. Fissure sealant retention almost always tends to be compromised if there's moisture contamination, as we had discussed in the previous slide. So we must practice good isolation techniques to prevent this problem, most commonly by making use of a rubber dam. If this moisture is compromised, we'll have to clean the tooth again, re-etch it, and apply the sealant. Okay, and sealants should always be checked by or examined carefully at routine checkups. As your slide also mentions, there could also be bite interference by the sealant in instances where the sealant is too high and may cause interference of the patient's bite. So it is very important that after the sealant is placed, we must check the bite once we are done. And then if it is too high, make use of a burr, be it a diamond burr or sometimes even finishing burrs, depending on the dentist, to actually reduce the height of the sealant and actually clear the bite. Okay, so we must then just basically be careful to place the sealant with just enough material and to just extend just beyond the pits and the fissures. So at the same time, we have to just ensure that the sealants then do not block the contact areas, because once too much sealant has been applied, we may have to spend even more time actually reducing the material and adjusting it accordingly. Okay, so if you do notice that there is excess material, especially when checking the occlusion or after the sealant is cured, remove it with a burr and or a scaler. I do not like a scaler personally because it tends to be quite aggressive or even cold for the patient, so it decreases the patient's cooperativeness. So personally, I wouldn't really recommend a scaler. but supposedly it is also advisable in such instances. Now, sometimes the sealant also remains intact, ladies and gentlemen, but can have chipped margins or areas of leakage. Now, if this happens, we run the possibility of having micro leakage associated with our sealant, and that area of micro leakage essentially becomes a possible point of dental decay, resulting in failure of what we were trying to accomplish with the sealant in the first place. Okay, so but even if, ladies and gentlemen, we have placed sealants in a patient's mouth during their regular dental checkups or visits, we have to run through with our intraoral mirrors as well as with our probes just to check those sealants, check the margins of those sealants, check occlusion on those sealants, just to make sure that everything is intact so that we do not cause more problems with dentistry onto our patients. I have mentioned earlier on, ladies and gentlemen, that there are some sealants that actually release fluoride beneath the tooth after polymerization, that is after actually curing the sealant. So those or that type of information you will find on the leaflet that is basically provided by the manufacturer as part of their instructions. Now, so the theory behind this is that fluoride release from the sealant creates a fluoride rich layer at the base of the sealed groove now after polymerization, as I'd mentioned before. So then with regards to the implication of topical fluoride in or by our patients, you wouldn't then, in such a case where you know you're going to place sealant, place topical sealant onto those teeth, because you're compromising the mechanical bond or the chemical retention or capability of that tooth to retain the sealant. But you can apply topical fluoride afterwards as indicated, but always try to make use of them manufacturer's instructions, especially in terms of curing and bonding and everything to that effect. Okay, and then this slide, ladies and gentlemen, just talks about the etching precautions for patients as well as for dental personnel, because the etching agent that is most commonly used contains 30% of phosphoric acid. Okay, that being said, I think it's basically obvious that every time we work in a dental space that we all must wear appropriate safety equipment. With that also then includes protective eyewear. Okay, so should an accident occur, I've yet to find an etching accident because of even like how they are stored or how we receive them from the manufacturer. It does not allow for accidents, but in the event that an accident would occur, obviously stop what we're doing, immediately stop the procedure. You or the patient would then have to go to the nearest tap essentially and expose or flush the exposed area immediately with a copious amount of water. And if eye contact is involved, immediately rinse the eye with plenty of water and seek medical attention. Like I said, I'm just running through this because I've yet to hear of an itching incident. Like, it almost doesn't happen. But anyway, yeah, let's just run through that. Okay, and then in terms of precautionary measures associated with sealant materials, you do find instances where patients actually come with acrylate allergies, or even you find practitioners with acrylate allergies. They are in the wrong profession, but that's neither here nor there. But in such instances, obviously, that's why we always encourage children to actually go to their clinics or hospitals, or even have allergy tests before actually making use of certain products and equipment and material. Okay, so that we actually try to minimize or altogether eliminate exposure to such materials. But should this occur, obviously we'd have to then stop the procedure again, remove gloves if possible, discard the gloves, wash hands with soapy water, and then re-glove. Okay, and then if there's any accidental eye contact, again, with just like with the itch, I've never heard of such an incident, but they do happen. In such an incident, again, flush with copious amounts of water, and then should the irritation persist, you would then have to go and seek out medical attention, as we had mentioned before. But I think more than anything with these precautions, it then also goes back to the initial fact that as a dental assistant or as a practice, we are expected, especially where kids are involved, to take thorough medical and dental history. You may also find yourself having to call a patient's physician to get extra information if there are or seemingly signs of possible allergies, or you need more clarity on a patient's medicine regimen, or you need more information on a certain medical condition. But yeah, I think that's saying to say the gist of what is being said with these slides. Okay, so with important information, like I mentioned before, always with every product, especially if you haven't used it before, carefully read and follow the manufacturer's instructions when applying or making use of a certain product. And then from there, application techniques and etching times may vary between manufacturers. Like, let's say if you find yourself having accidentally bought a tooth system sealant, obviously then it will differ from a light cured dental sealant. So those are the things that we're talking about with this particular point, né? And then, for example, some manufacturers discourage the use of polishing paste that contain fluoride, while others do not consider fluoride polishing paste to be contraindicated. So we do not want to affect the patient's treatment or even our desired results. So it's always helpful to follow the manufacturer's instructions, okay?